Radioactive iodine therapy for differentiated thyroid cancer. Here we have two examples, patients A and B. Patient A is a relatively younger woman who is clinico-radiologically node negative, undergoes total thyroidectomy, multifocal classic PTC, largest nodule is 1.5 centimeters. On the other hand, patient B is relatively older, age above 55, upstages the disease. She had clinically node positive disease, undergoes thyroidectomy with neck dissection, slightly larger nodules, again multifocal classic PTC, 18 lymph nodes metastatic. The AJCC staging is significantly different for both these patients. For most cancers, we at the end of the histopathology report, we arrive at the AJCC, decide adjuvant therapy. But for thyroid, we need to calculate two other parameters: the risk of recurrence, response to therapy. Risk of recurrence is quite literally the risk of recurrence, calculated by a combination of histopathological factors, can be as low as less than 10% to as high as more than 30%. I've made it a very simple and easy to remember tabular column. So, though both of our patients fell into different AJCC staging, if we put both of our patients in this tabular column and calculate the risk of recurrence, both will end up in the same ATA, high intermediate risk of recurrence category. So, 50% of the job is done. This does not complete the picture. This is the most important part to remember now. We have done only half the job. That is, we have calculated only the risk of recurrence. What next is that we need to calculate the response to therapy. What therapy has been done? We have done the surgery. For one patient, we did thyroidectomy. For the other patient, we did thyroidectomy with neck dissection. That is the therapy that we have offered. So, we need to evaluate how effective that therapy has been for each of those patients. It is as simple as that. Risk of recurrence tells us how aggressive the tumor was when the tumor was in the patient's body. Had it already spread to lymph nodes? Did it have an aggressive biology, histology, all that? Response to therapy evaluates how effective the therapy has been. Rather, in very simple terms, for our post surgery evaluation, response to therapy simply evaluates how good the surgery was. In plain English, it evaluates how effective or how good the surgery was. So, all patients, even ATA low risk patients, should undergo post operative evaluation of response to therapy. So, the histopathology gives us risk of recurrence. So, this can be low, low intermediate, or high. All these four categories should undergo the next step: evaluate how effective the surgery has been. So, how to do that? We calculate thyroglobulin and we do a diagnostic RAI scan. So, if there's any functioning thyroid tissue in the body, the thyroglobulin will be elevated. If there's any functioning thyroid tissue in the body, the diagnostic RAI scan will pick it up. It is as simple as that. So, in the past, there was some controversy about diagnostic RAI scans, which no longer exist. And one more important point that I'd like to convey: even low risk patients, it is ideal to undergo the diagnostic RAI scan, because in a not negligible number of patients, low risk patients, the diagnostic RAI scan can pick up previously unidentified and unrecognized local regional metastasis, which can be in the central compartment or lateral compartment lymph nodes, which were not picked up on the ultrasound, things like that. So it's not a rule that low risk patients should not undergo radioactive iodine therapy. Even some low risk patients may have to be treated with RAI. So, in very, very, very simple terms, these were our two patients, A and B, with different AJCC staging but with the same ATA, high intermediate risk of recurrence. Now, the recommendation for high intermediate is 30 to 100 millicurie, but it's not as simple as that. So, we need to understand these possible scenarios. This is the most important slide of the video. So, let's take this scenario. Patient A, post-operatively, she had multifocal classic PTC. Largest nodule was only 1.5 centimeters. Nodes were not addressed. But post-operatively has a thyroglobulin of 12, meaning There is some functioning thyroid tissue does not mean malignant tissue. Normal thyroid tissue also produces thyroglobulin. Thyroid cancer also produces thyroglobulin. This just means there is some functioning thyroid tissue in the patient's body. And the diagnostic scan is showing an uptake of 12% in the neck. This could mean a lot of things. One, the surgeon might have been inexperienced, or the surgeon might have been experienced and good. He might have deliberately left behind a normal fragment of thyroid tissue to preserve the RLN or a parathyroid, which is a very common scenario. So that is why this patient, though patient A, though as per the histopathology report, had a less aggressive disease compared to patient B, now will have to be treated with a higher dose of radioactive iodine compared to patient B because of the structural incomplete response, meaning structural presence of functioning thyroid tissue. Whereas patient B, though 18 lymph nodes had metastatic PTC, postoperative response to therapy assessment has a thyroglobulin of 0 and less than 4% uptake in the neck, no other uptake in the body, meaning, in very simple terms, that the surgeon has done a phenomenal job. So, compared to patient A, though patient B had an aggressive disease based on the histopathology, now has an excellent response. So, may be considered for a lower dose of radioactive iodine compared to patient A, right? So, this is another scenario. Patient A itself, thyroglobulin is elevated, but the RAI scan is not showing any uptake, meaning a biochemical incomplete response. There is some tissue somewhere, but it's not picking up. So this is called a biochemical incomplete response. Again, calls for a slightly higher RAI compared to the excellent response category. Now, another scenario, patient B, 18 metastatic lymph nodes, postoperative response to therapy assessment. So if this is not done, for example, so she had fallen under the ATA high intermediate risk of recurrence category. The dose required is 30 to 100 millicurie. If we had blindly given that, we might have missed something. Whereas the response to therapy assessment correctly picked up a thyroglobulin of 20 and some lung meds. So maybe requiring a slightly higher dose of RAI. So this is why both the halves are important. The histopathology report gives us the risk of recurrence, that is one half of the story. That is, this tells us how aggressive the tumor was, and this tells us how aggressive the surgeon was. It's as simple as that. Post-operative response to therapy with thyroglobulin and an RAI scan gives us four response categories, a combination of which will help us in deciding the exact dose of radioactive iodine therapy. So, yes, all based on the histopathology report, we know even intermediate risk should be considered strongly for radioactive iodine therapy. So, both these patients, when the histopathology reports come, we know at this point, right now, we know that both these patients will require radioactive iodine therapy. But the refinement of dosing is done by this evaluation of response to therapy. So, that is why risk of recurrence plus response to therapy gives us the exact